Good morning to all. Today we are going to discuss about patient positioning in anesthesia. Introduction. The surgical posture denotes the body position in which a patient is placed during an operation. Also, it describes a posture that serves the single purpose of offering to the surgeon the maximum acceptable access to the anatomic target. The reference was taken from the effects of body position on anesthesia by Lateral and the circulatory, respiratory, and neurovascular complication from Slocum 1947. Absence of pain under anesthesia permits the patients to be placed in position that would be intolerable when awake. It also permits prolongation of surgery beyond limits of postural tolerance. In both the cases, patient suffers a lot. Components of safe positioning. What are the components of safe positioning? Knowledge, forethought, teamwork, and housekeeping. These four things are essential to keep the patient position safe under anesthesia and patient to be feel very comfortable after the surgery or anesthesia. Knowledge, it is comprises understanding the principle of arranging the posture of the patient. Forethought, to understanding of the intended operation and the specific problems. Teamwork, having a sufficient number of personnel to changing the posture of the patient during the surgery for the convenience of the surgeon and to prevent the harmful of the patient. Housekeeping, devices that needed for the patient positioning and having each of the parts in working condition. The ability to tolerate postural stresses depends on the patient's preoperative condition. Patients with prolonged bed rest that's more than 2 to 3 weeks have negative sodium and potassium balance, reduced plasma volumes, and exaggerated responses of heart rate, stroke volume, cardiac output, and peripheral vascular resistance. Positional problems discovered at the PAC should be commented upon in an obvious manner in the patient's medical record. Also, the history of diabetes mellitus, stroke, or any other peripheral nerve injury must be documented on the records. The various positions we would be studying are supine position, lithotomy position, lateral position, prone position, sitting position. Among the supine position, there are various types, that is lawn chair position, Trendelenburg position, reverse Trendelenburg position, frog leg position. These positions, we keep the patient in these different kind of positions for different kind of surgery to keep the surgeon in a comfortable way to operate for the optimal surgery. This picture depicts the supine position, which can also be called as dorsal decubitus, where the patient back of the head, back of the back, and back of the leg, everything is placed on the table. Note the asymmetry of the base of the table, placing the patient's center of the gravity over the base, position in the usual direction. This is the most common position for surgery. where the hemodynamic reserves are very well maintained. Compensatory mechanisms blunted by anesthesia. No skin to metal contact should be there. Bony contact points at the occiput, elbow, and heel should be padded. This kind of positions are used in the neurosurgery, ENT surgeries, breast surgeries, laparotomies, and, and any abdominal surgeries. In dorsal decubitus position, arms can be abducted or adducted. In case of abduction, the abduction should not be more than 90 degrees. It should be always less than 90 degrees to minimize the brachial plexus injury. It should be guarded by placing the corded pad in the axilla to minimize the brachial plexus injury. In adducted position, in adducted position, it should be held alongside the body with a drawstring. Elbow to be padded in both sides. Hands and forearm, it should be in the supinated or neutral position to reduce the external pressure on the spiral groove of humerus and ulnar nerve. This picture shows the arms are in the abducted position but in the less than 90 degree in dorsal position. Also, the arms are supinated and elbow is padded, thereby preventing the elbow to have a direct contact on the table. Here, the dorsal decubitus with the arms are tucked by the patient's side. Arm in neutral position with palm to hip. The elbow is padded and one needs to ensure that the arm is supported. Physiology of dorsal decubitus position. In While we place a patient in the supine position, there will be some there will be some physiological changes happen in the body. The circulatory system, what happens is in the horizontal supine position, due to the influence of gravity on the vascular system is minimal. If patient's head is tilted high or low of the gravity can become significant as gradient to or from the heart increase. Pressure changes by 2 millimeter of mercury per each 2.5 centimeter at a given point varies in vertical height above or below the reference point at the height heart. In the respiratory system, mobile abdominal viscera gravitate towards the dorsal body wall and versus the dorsal parts of the diaphragm. This lengthens the muscle fiber of that portion of the diaphragm and increases strength and effectiveness of its concentration during spontaneous ventilation. Also, gravity-induced vascular congestion forces the dorsal portion of the lung to function as zone 3. Complaints of the area is reduced and passive ventilation tends to distribute gas preferentially to substernal units where the pulmonary blood volume is less. To prevent ventilation perfusion mismatch during controlled ventilation, larger tidal volume must be used. Variation of supine position. As we have already seen in that slide, there are various supine positions are there. The first one is non-chair position. Here it shows the normal non-chair position where it is slightly different from the normal dorsal Decubitus position. Here, flexion of the hips and knees are occurred, slightly occurred, and compared with the dorsal Decubitus position. Due to this flexion of the hips and knees decreases the tension on the back. It also promotes slight venous return from the leg towards the heart, thereby increase the venous return, thereby it helps in the hemodynamic, which is to maintain the hemodynamics. Non-chair position is achieved by angulating the trunk thigh inch of the OT table by 15 degree and the thigh knee hinge by the same 15 degrees in the opposite direction. This reduces stress on the back, hips, and knees. It is the best tolerated position by the awake patient. Legs above the heart, so which leads on to the good venous return from the leg to the heart for maintaining the hemodynamics. Xiphoid process to pubic symphysis is decreased. Thereby, tension on the ventral abdominal wall is also decreased. So, for any abdominal surgery for laparotomy, the closure of the abdominal wall will give less tension to the surgeon for the better closure. Trendelenburg and reverse Trendelenburg position. In this Trendelenburg and reverse Trendelenburg position, heads are placed down or upside. So due to this position, patient may fall from the table. However, shoulder bases should be avoided to prevent brachial plexus compression injuries. First, we see Trendelenburg position. Tilting a supine patient's heads down 10 to 15 degrees from the horizontal axis is used in this position since the head is slightly lower than the heart level. There will be increased venous return from the leg, which helps in maintaining hemodynamics, especially during hypotension. To improve exposure during abdominal and laparoscopic surgery, especially for the pelvic laparoscopic surgery, we keep the patient in Trendel position to keep the abdominal viscera towards the scapula, thereby give the space for the surgeon to operate in the pelvic region. It is also this position is also used to prevent air emboli and facilitate cannulation during central line cannulation. During central line cannulation, especially the IJV, we keep the patient in the head down position. Thereby, it prevents any air embolization entering into the venous system and thereby it lead to air embolism. So, keeping the patient in Trendelenburg position during central line cannulation, it prevents air entering into the venous system and thereby prevents air embolism. The matter should be used so that it prevents the sliding of the patient from the table. Shoulder plexus are better to be avoided to prevent the brachial plexus injuries. Effects on various system of Trendelenburg position. Due to the head-down position, there is increased blood flow to the cerebrum, leading to increased cerebral blood flow, which and thereby increases the intracranial pressure. In cardiovascular system, it increases the central venous pressure because of a increased venous return from the leg to the heart, and that is and thereby increasing cardiac output, thereby increasing blood pressure. In eye, there is an increase in intraocular pressure, may precipitate glaucoma. One has to take care of the eye. Also, due to prolonged surgery in the Trendelenburg position, venous return and cooling of blood in the face or in the below the level of the heart, that is towards the caudal side, leads to swelling of the face, conjunctiva, larynx, and tongue, leading to increased chance of post-operative upper airway obstruction. This swelling occurs due to venous congestion occurs in the face. On the respiratory system, due to diaphragm moving towards the lung, so there is decrease in FRC and pulmonary complaints, and thereby due to decrease in FRC, there will be increase in work of breathing in spontaneous breathing patients. Whereas in mechanical ventilated patients, there will be increased airway pressure to push the air inside the lung against the diaphragm. Endotracheal intubation preferred to avoid pulmonary occlusion, which means by keeping the patient slightly head low during endotracheal intubation with the full stomach patient, if there is a vomitus happening during intubation, by keeping the patient head down, we can prevent the vomitus going into the airway and thereby to avoid the pulmonary aspiration. Reverse Trendelenburg position. Here it is reverse to the Trendelenburg position. That is, head is up, slightly tilted upside. This facilitates the upper abdominal surgery by shifting the abdominal contents harder. Mainly, we can say for the laparoscopic cholecystectomy. Like in Trendelenburg position, here also we should be very careful that patient should not sleep from the table. More frequent monitoring of blood pressure is required due to decreased venous return. So hemodynamic collapse may occur. Perfusion pressure of the brain is decreased. So one has to maintain the adequate mean arterial pressure to maintain the cerebral blood pressure and cerebral blood flow. The last one we are going to see in dorsal Decubitus position is frog leg position. The picture depicts the frog leg position. Frog leg position. Here the hips and knees are flexed. Hips are externally rotated. Soles of the patient facing each other allows access to the perineum, medial thighs, genitalia, and rectum. Care to be taken to minimize post-operative pain in the hips and to prevent dislocation of knees by supporting the knees, and also stitching may cause injury to the obturator nerve. Complications of supine position. Complications can occur in any position. Likewise, in supine position, due to the pressure on the head, which may lead to pressure alopecia, backache, peripheral nerve injury. Complications with supine position. Pressure alopecia. Pressure alopecia, which occurs resulting from the ischemic hair follicles due to prolonged immobility stabilization of head with its full weight falling on a limited area. Hypothermia and hypotension during surgery may increase the incidence. Cushion and cushion the head well. That is, you should always keep the head rings to prevent the pressure falling on a single limited area. If possible, periodic rotation of the head to distribute the weight, which can also prevent the pressure falling on one particular area, which may lead on to ischemic hair follicles due to pressure alopecia. So, periodic rotation of the head and keeping the head rings to distribute the weight of the head to fall on limited area, thereby prevent the complication like pressure alopecia and supine position. Bracket. Normal lumbar lordosis and tone of the spinaspinal musculature is lost under general anesthesia. Patients with extensive kyphosis, scoliosis, or previous history of the back pain require extra padding of the spine or slight flexion of the hip and knee. Tissues overlying all bony prominences such as heel, sacrum to be padded. Peripheral nerve injury. Serious perioperative complications occurs due to stretch, ischemia, or compression. Ulnar neuropathy is more common in supine position than the second most is brachial plexus injury and lumbosacral nerve root or spinal cord injury can also occur. Spinal cord injury and nerve root neuropathy mostly occur due to regional anesthesia, whereas the reason for injury to brachial plexus and ulnar nerve largely remain unknown because injuries have occurred in presence of adequate positioning and padding also. However, better we avoid the hyperextension, that is abduction more than 90 degrees in position. Thereby, the stretching of the brachial plexus in the axilla can be prevented to prevent brachial plexus injury. The most common nerve injuries in American Society of Anesthesiologists. Ulnar nerve is most common, showing 25%, which can be avoided. The recommendation for prevention is avoid excessive pressure on postcondylar groove of humerus. Keep hand and forearm either supinated or in neutral position. Brachial plexus has 19% chances of getting injured in the dorsal Decubitus position. To avoid this, avoid the use of shoulder braces in patients in Trendelenburg position for non or to prevent sliding, or better to use the non-sliding mattresses. Avoid excessive lateral rotation of the head in either in supine or prone position. Limit abduction of the arm to less than 90 degrees in supine position. Avoid placement of high axillary roll in Decubitus position. Keep roll out of the axilla. Use ultrasound to find internal jugular vein for central venous line placement. Spinal cord accounts for 16% and lumbosacral nerve root accounts for 15% chances of getting injured in supine position. Be aware that the fraction of spinal cord injuries is increasing probably in relation to the use of epidural catheter for pain management. Follow current guidelines for regional anesthesia in anticoagulated patients. Sciatic and peroneal nerve has chance of 5% to get injured in supine position. To minimize this, to minimize the time of surgery in lithotomy position, Use two assistants to coordinate simultaneous movement of the both legs and to and from lithotomy position. Avoid excessive flexion of the hips, extension of the knees, or torsion of the lumbar spine. Avoid excessive pressure on peroneal nerve and the fibular head. Median and radial nerve injury. To avoid this, be aware that 25% of injuries to the median and radial nerves were associated with axillary block, and 25% of the injuries were associated with traumatic insertion or infiltration on an intravenous line. Ulnar nerve neuropathy. Incidence is low, but morbidity is severe. Presents with a delayed onset with median 3 days. Permanent damage leads to inability to abduct or oppose the fifth finger. Diminished sensation in the fourth and fifth finger. Atrophy of the intrinsic muscles of the hand leading to claw hand. These are all the signs of the ulnar nerve neuropathy. ETR is multifactorial and not always preventable. Compression by the operating room table of the nerve at the condylar groove and the cubital tunnel against the posterior aspect of the medial epicondyle of the humerus. Risk factors are old men, diabetes mellitus, vitamin deficiency, alcoholism, cigarette smoking, cancer. Brachial plexus injury. Susceptible to injury from stretching and compression. Injury most commonly due to arm abduction greater than 90 degrees, lateral rotation of the head, asymmetric retraction of the sternum for IME dissection, direct trauma, direct compression with shoulder braces in patients in Trendelenburg position. Other upper extremity nerves. Radial nerve injury is mostly occurred due to direct pressure while it goes in spiral groove. It's manifested as wrist drop, inability to abduct the thumb or extend the metatarsophalangeal joints. Median nerve injury is mostly due to insertion of the intravenous line in antecubital fossa. So, signs include inability to oppose the first and fifth digits, decrease in sensation over the palmar surface of the lateral 3 and 1/2 fingers. Coming to lithotomy position, here the picture shows the lithotomy position. Here the hips are flexed 80 to 900 degrees with lower leg parallel to body. Arms are on the armrest away from the hinge points of the foot section. Candy can suppose. In during lithotomy position, we can also use the candy can to support the legs. Here the support which is called the candy can supports. One should be very careful on keeping the patient's hand in lithotomy position. Improper position of the arms in lithotomy position with fingers at risk for compression when the lower section of the bed is raised. Keeping the arm by the side of the patient in lithotomy position is increase the risk of getting the fingers to get into the lower section of the bed. It's better to keep the patient away from the body of the patient. As I already told, in lithotomy position, hips are flexed in 80 to 100 degrees from the front. Legs are abducted 30 to 45 degrees from the midline. Knees flexed until the lower legs are parallel to the torso and legs are held by supports or stirrups. Usually, candy cane, knee patch, or calf support style. Foot section of the table is lowered. Arms should be positioned far from the table in joints in order to provide crush injury at the fingers. Doing anatomy position, at least two assistants are required to avoid any nerve injuries during the position. Two assistants required to raise both the legs together by flexing the hips and knees simultaneously to avoid torsion of the lumbar spine. Lower extremities padded to prevent compression against stirrups. After surgery, patient should be returned to spine position in a coordinated manner. Legs removed from the holders simultaneously, knees brought together in the midline, and legs slowly straightened and lowered onto the OT table. Physiological changes in lithotomy position. In cardiovascular system, increased preload leading to increase in cardiac output, central venous pressure, whereas in central nervous system, due to increased blood flow from the leg by the raised leg, leading to increased cerebral blood flow and increased intracranial pressure. On the respiratory system, due to the legs are in the raised condition, abdominal viscera displaces the diaphragm towards the capillary and thereby reducing the lung complaints and the apathy, resulting in decreased tidal volume. Increased abdominal pressure obstructs the venous return to the heart. On spine, normal lordotic curvature of the lumbar spine is lost in the lithotomy position, that thereby aggravating any lower back pain. So prolonged surgery in lithotomy position might lead up to a back pain. Complication of lithotomy position. The most common nerve injury is the common peroneal nerve. Most common lower extremity motor neuropathy, accounting for 78% of the injuries. Seen most commonly in patients with lower body mass index, recent cigarette smokers, or prolonged duration of the surgeries. Also seen as paresthesias in the distribution of the obturator, lateral femoral cutaneous, sciatic, and peroneal nerves. Lower extremity compartment syndrome, which is a very rare complication in the lithotomy position, occurs due to inadequate perfusion leading to ischemia, edema, and extensive rhabdomyolysis. Recommended to lower the legs to the level of the body periodically if surgery extends for a longer duration. Lateral decubitus position. The lateral decubitus position, use of axillary roll in the lateral decubitus position, this picture shows. Roll in this case, a bag of intravenous fluid is placed well away from the axilla to prevent compression of the axillary artery and the brachial plexus. Lateral decubitus position most commonly is used for surgery involving the thorax, retroperitoneal structures, and hip. Patient rests on the non-operative side and is balanced with anterior and posterior support, such as bending rolls are a being back and a flexed dependent leg. Arms usually positioned in front of the patient. Dependent arm rests on a padded arm bow perpendicular to the torso. The non-dependent arm is often supported over folded bending or suspended with an armrest or foam cradle, not to be abducted more than 90 degrees. That has to be kept in mind. Head to be kept in neutral position. This is to prevent excessive lateral rotation of the neck and stretch injuries to the brachial plexus. Dependent ear should be checked to avoid folding and undue pressure to prevent the ear cartilage necrosis. Eyes should be securely taped and dependent eye to be checked for any external compression. Dependent brachial plexus or vascular compression can be avoided by placing an maxillary rod just parallel to the dependent axilla. Rod not to be placed in the axilla as we have already seen in the picture. It might keeping a pad in the axilla might compress the axillary artery or may compress the brachial plexus. Purpose is to ensure that the weight of the thorax is borne by the chest wall caudal to the axilla and avoid compression of the axillary contents. Pulse should be monitored in the dependent arm for early detection of compression to the axillary neurovascular structures. Hypotension in the dependent arm may be due to axillary arterial compression. Kidney is to be properly placed under the dependent iliac crest to prevent compression of the inferior vena cava. Pillow or other padding to be placed in between the two knees to prevent excessive pressure on bony prominences and stretch of lower extremity nerves. Patients may be flexed while in the lateral position to spread the ribs during thoracotomies or improve exposure of the retroperitoneum for renal surgeries. The point of flexion should lie under the iliac crest rather than the flank or ribcage to minimize compression of the dependent lung. The flexed lateral decubitus position. Point of flexion should lie under the iliac crest rather than the flank or the lower ribs to optimize ventilation of the dependent lung. Physiological changes in lateral decubitus position. As in cardiovascular system, venous return decreases followed by decreased in stroke volume and cardiac output. In respiratory system, in awake patient, dependent lung ventilated more and perfused more, and so ventilation perfusion relationship is not altered greatly than supine position. That is, in awake position, dependent lung gives ventilation as well as the perfusion, both are in the same direction, that is in this direction. So the ventilation perfusion mismatch does not occur. In paralyzed patient, that is in patient who is on mechanical ventilation, non-dependent lung ventilated more, but dependent lung perfused more. So lead on to ventilation perfusion mismatch occurs. Picture shows the prone position with Mayfield headpins. Rigid fixation is provided for cervical spine and posterior intracranial surgeries. Head position may include neck torsion or flexion that affects endotracheal tube position. Prone position, which can also called as ventral Decubitus position. This kind of position are used in surgeries of posterior cranial fossa of the skull, posterior spine surgeries, buttock regions, perirectal area, and the lower extremities. Legs are in plane with the torso. Legs should be padded and flexed slightly at the knees and the hip. Elastic stockings and active compression devices for the legs are to be used for the better venous return and to avoid the venous pulling in the leg. Arms should be positioned by the patient side and tucked in the neutral position or placed next to the patient's head on the arm boards. That position is called prone Superman position. Extra padding under the elbow to prevent the ulnar compression. Arms not to be abducted more than 90 degrees. Head position, which is very crucial, can be turned to the one side if cervical arthritis or the jugular vein is compromised by the lateral position of the head, then head is kept in a neutral position using a surgical pillow, horseshoe headrest, or Mayfield headpins. Pillows available are disposable foams version which help support the forehead, malar region, and the chin with a cutout for eyes, nose, and mouth. Mirror systems are also available to facilitate the intermittent visual confirmation. Here the mirror system in the whole position with the headrest showing eyes and nose are pressure free. Bony structures of the head and face are supported and eyes are eyes can be very easily monitored and the tube endotracheal tube is also very well easily monitored through the mirror. Horseshoe adapter. Horseshoe headrest supports only the forehead and the malar regions. Allows excellent access to the airway. Width can be adjusted to ensure proper support by the facial bones. Mayfield headpins. Mayfield pins support the head without any direct pressure on the face, allow access to the airway and hold the head firmly. Pins cause periosteal stimulation. Skidding out of pins can lead to scalp laceration and cervical spine injuries. Head, eyes, always must be checked periodically to ensure weight is borne by the bony structures and there is no pressure on the eyes. Eyes should be properly padded to prevent perioperative vision loss. Thorax supported by the firm bolts or bolsters placed each side from the clavicle to the ear crest. Male genitalia and female breast should be kept free of compression. Breast should be placed medial to the bolster. Commercial rolls and bolsters include the Wilson frame, Jackson table, Hilton frame should be used. Lower portion of the each roll and bolster must be placed under its respective ear crest to prevent pressure injury to the genitalia and femoral vasculature. Prone position is key for obese patients. Sometimes it may be necessary to discuss alternative position option with the surgeon. Physiology of prone position. Respiratory system. Increased intra-abdominal pressure pushes the diaphragm capillary, thereby decrease FRC and increase the peak airway pressure. And central venous system, increased abdominal pressure impedes venous return, thereby decrease cardiac output. CNS, if head below the level of the heart increase the ICP is seen. Head rotation may threaten perfusion of the cervical cord and brainstem, cerebellum, and cochlear vestibular apparatus. Elevated intra-abdominal pressure in the prone position transmits the elevated venous pressure to the abdominal and spine vessels, including the epidural vessels. While doing spinal surgery, low venous return is desirable to minimize bleeding. Complications. Perioperative eye injury and visual loss. It's quite rare, but source of significant morbidity and liability are there. Corneal abrasion is the most common type of perioperative injury due to direct trauma to the cornea from the face mask, surgical grapes, or other foreign objects, swelling of the dependent eye in patients with position. Symptoms are transient, treatment, supportive care, and antibiotic ointment. Visual loss is a devastating complication, occurs in the prone position, more common for patients undergoing non-cardiac and non-ocular surgery. The risk varies from 1 in 60,000 to 1 in 1 lakh. Patient undergoing cardiac surgeries, the risk of 0.06 to 0.113%. Spine surgeries, the risk is 0.09%. The causes are for visual losses, ischemic optic neuropathy, central retinal artery occlusions. Factor affects the increased risk of optic neuropathy, ischemic optic neuropathy, or perioperative factors are prolonged hypertension, long duration surgery, large blood loss, large use of crystalloids, anemia, or increased IOP. Patient factors include the hypertension, diabetes, atherosclerosis, morbid obesity, and tobacco use. So, to avoid the perioperative visual loss, always discuss the spine surgery with the surgeon. Avoid excess increased in IOP from the head position. Keep the head in neutral. Use colloid along with crystalloids to maintain intravascular volume. For patients with anticipated prolonged surgery, substantial blood loss, consider explaining the small unpredictable risk to the risk of perioperative vision loss. The cause of perioperative vision loss seems to be multifactorial in nature, with no consistent underlying mechanism with the exception of obvious external compression. Sitting posture with the Mayfield means this is actually modified recumbent position as the legs are kept as free as possible to promote venous return. Arms must be supported to prevent shoulder traction. Used infrequently used for approaching posterior cervical spine and posterior fossa surgeries. The advantages of to surgeon of sitting position over prone position is excellent surgical exposure, decreased blood in the operative field, reduced perioperative blood loss. Advantage to anesthetist, superior access to the airway, reduced patient swelling, improved ventilation, particularly in obese. Head fixed imprints for neurosurgery are taped in place with adequate support for other surgeries. Knees are usually slightly flexed for balance and feet are supported and padded. Physiological effects of sitting posture is in CVS, decreased intrathoracic blood volume, decreases cardiac output and stroke volume. Respiratory system, sitting position permits downward displacement of the diaphragm that way, free diaphragmatic movement. Spontaneous respiration, little restriction to expansion of the anterior chest wall. Complications are the pooling of blood in the lower body and the GA. Patients are more prone for hypertensive episodes. Excessive surfactant suction leads to impairment in arterial venous blood flow, causing hypoperfusion or venous congestion of the brain. Venous air embolism is a constant concern. Paradoxical embolism. Excessive fluxion can also obstruct the endotracheal tube. Post-tonsillectomy position. This is the miscellaneous position. Positioning the patient laterally to allow the secretion to drain away from the hypopharynx. Downside leg straight. Upside leg flexed at the knee and the hip. Upside arm flexed with the pointed hand near the head. Downside arm is extended slightly behind the patient also. Left lateral different displacement position. This is for the pregnant patients. Obstruction of the IBC and distal portion of the aorta caused by the increased mass of the uterus during the second and third trimester of pregnancy patient, and its functions lead to serious pitfall during pregnancy. For preventing this, 10 to 12 centimeter bed should be placed under the right hip of the parturient to prevent the compression of IBC and the distal portion of the aorta. Thank you.